Good morning, everyone. Thank you so much for joining us for this great Grand Rounds. I have the pleasure of introducing our speaker today. Dr. Jennifer Marin is an Associate Professor of Pediatrics, Emergency Medicine, and Radiology at the University of Pittsburgh School of Medicine, and a faculty member in the Division of Pediatric Emergency Medicine. She serves as Director of Emergency Ultrasound for the Division of Pediatric Emergency Medicine and as Medical Director for Point of Care Ultrasound, the UPMC Children's Hospital of Pittsburgh, one of the few pediatric hospital-wide programs in the country. Dr. Marin completed a pediatric residency at Ann Robert H. Lurie Children's Hospital, followed by a pediatric emergency medicine fellowship at Children's Hospital of Philadelphia, during which time she earned a Master's of Science degree in clinical epidemiology. She subsequently spent an additional year learning point-of-care ultrasound in the Department of Emergency Medicine at the Hospital of the University of Pennsylvania. One of the pioneers in pediatric point-of-care ultrasound, Dr. Marin has published extensively in the field and lectures and teaches internationally. Dr. Marin's research focuses more widely on optimizing emergency diagnostic imaging, including utilization patterns and variations in care delivery. She has over 100 publications, and much of her work has garnered local and national media attention. Thank you so much for joining us, and we are excited to have Dr. Marin for our talk today.
All right, bear with me as I get these slides up and running. All right. Everyone can see my slides? All right. Thank you so much, Maya, and thank you all for joining me today. As Maya said, I'm going to be talking about point-of-care ultrasound, pediatric care in the 21st century. By way of disclosures, I serve on the medical review committee for Highmark. So let's get started. These are the educational objectives for my talk today. First, to describe the differences between point-of-care ultrasound and comprehensive ultrasound exams. And I'm going to refer to this as POCUS moving forward. To identify pediatric subspecialties currently utilizing POCUS and the relevant diagnostic and procedural applications. And finally, to list some of the challenges and barriers surrounding POCUS in pediatrics. People sometimes ask me how I became interested in and involved in POCUS. My very first month of my fellowship was on the adult trauma rotation. And my role as the pediatrics fellow was to perform the primary and secondary survey. So this is the initial assessment that we do in trauma patients when they present to the emergency department. And this is Vince Gracias. He's an adult trauma surgeon. And at the beginning of my rotation, Dr. Gracias was on service. And in the middle of my survey assessment, he yelled at me with this big booming voice, "Jennifer, do the FAST." So if you're not familiar with the FAST exam, I'll tell you that it's the ultrasound exam that we do to evaluate for hemoperitoneum as part of our initial assessment. But many years ago, which is when I was doing my fellowship, I, of course, didn't know this at the time. POCUS had not made its way to pediatric medicine. And initially, I didn't really understand what he was asking me to do. And so I thought maybe he's asking me to move a little faster. And it quickly became abundantly clear to me as the volume of his voice continued to rise that I was not doing what he was asking me to do. So thankfully, one of the trauma seniors rescued me and I think probably took pity on me and just did the FAST exam for me. So for me, in my life, I'm motivated by two things. One is fear and the other is humiliation. And that experience in the trauma bay that day really left me feeling both of those things. So I went home and decided at that point that I was going to become an expert in this so-called FAST exam. But remember, my experience was several years back when POCUS was not being routinely done in pediatrics. It was almost exclusively actually being done in adult patients. So I was tasked with trying to figure out how I was going to learn this. So after my trauma rotation, I went back to the adult hospital and I reached out to this man. This is Anthony Dean, who is arguably one of, if not the godfather of emergency ultrasound. And he happened to be next door at the adult hospital and was kind enough to take me under his wing. And he became one of my mentors. He and his ultrasound fellows over the years of my fellowship trained me, and he and I still collaborate today. So that's my story. And now I want to tell you about using POCUS as a tool in pediatric medicine. So here's my outline. And even though I am a pediatric emergency physician, this talk is not just about emergency POCUS, but rather it's going to be about POCUS more broadly in all areas of pediatrics. So I'm going to talk to you about what POCUS is, why it's important, when we use it, what we're doing locally, and what I believe are the next steps. So first, I want to make sure that we're all on the same page when we talk about POCUS. And by the way, there are several terms for this modality. So you might hear people call this clinician-performed ultrasound or bedside ultrasound. Simply put, POCUS is the integration of an ultrasound exam at the point of care with the history and physical exam. And with POCUS, we as bedside clinicians also become the sonographers. POCUS is designed to answer simple yes/no questions. For example, is there fluid? Is there a stone? Is the bladder full? And our examinations are usually characterized by 1 or 2 easily recognizable findings. It's available 24/7, immediately without any wait time. And it's quick. Usually we can do these exams in under 5 minutes. It's performed at the bedside without the need for transport, and this becomes particularly important with our critically ill and injured patients. And it's repeatable. So patients' clinical status is not stagnant, particularly in the acute care settings. So as that status changes and as we make interventions, we can repeat the study over time and reassess the patient. Another very key feature of POCUS is the equipment that we use. And if you're familiar with Moore's Law, it absolutely applies to ultrasound equipment as well. So Moore's Law was originally applied to computers, and it states that the speed and capability and just the overall power of computers increases every 2 years. And at the same time, the size and the cost will continue to decrease. This is exactly what happened with ultrasound. Earlier ultrasound machines were overly cumbersome, not at all user-friendly, and prohibitively expensive. But over time, they became faster, provided better images, and at the same time were more compact and portable, and importantly, less expensive. You can see the Butterfly IQ ultrasound over on the far right, runs about $2,000 and attaches to a smartphone. So clinicians can now use their CME money to buy ultrasound equipment. It's important for me to also clarify what POCUS is not. And I do want to emphasize that this exam is in no way meant to supplant more comprehensive and detailed studies from my colleagues in radiology, cardiology, and obstetrics, for example. Our goal is not to diagnose a patient with portal vein thrombosis or pulmonary stenosis, or to evaluate a fetus with a congenital malformation. Rather, what we want to know is if a patient with flank pain, for example, has hydronephrosis from an obstructing stone, or if a patient with fever and asymmetric breath sounds has a pleural effusion. And I want to put all of this into some historical perspective. I created this timeline purely to draw your attention to the year on the left here, 1976. This is when surgeons began using this technology. And I point this out to illustrate that this isn't new. It's been around for decades. It's just more recently that pediatrics has begun to embrace it. So why is POCUS important? So it's very portable and it's convenient, but beyond that, why is it useful? And there are several reasons. First, I want to show you that the volume of POCUS literature is rapidly increasing. This graph shows you the number of publications in PubMed each year since 2005, and it goes through November of 2019. And this growth is really a testimony to its scientific validation and the growing importance of POCUS in medicine. Although more data continues to emerge in many different areas, most of the literature to date of POCUS is really in general emergency medicine, because emergency medicine has been using it consistently for decades, incorporating many different applications. The literature has shown that POCUS is accurate, decreases patient length of stay in the emergency department, reduces complications, and improves patient satisfaction. And the reference list that I have at the bottom here is in no way meant to be comprehensive. There are many others in both the general and the pediatric emergency medicine literature. We all know that we practice in an era where safety is certainly paramount, and I want to talk now about how POCUS should be viewed as a safety measure. And we're going to use ultrasound-guided central line placement as the prototypical example here. And many of you in the audience probably remember learning to place central lines blindly using landmarks only without ultrasound guidance. And needless to say, it took many of us more than one attempt before we were successful. That's certainly how I learned as a resident. There was not an ultrasound machine to be found anywhere in the PICU. And we know from the literature that blind insertion can result in up to a 20% rate of failure, and complications can be seen in up to 10% of cases. Many studies have been done that use ultrasound, that have looked at ultrasound when placing central lines and shown that it reduces complications and improves success. And there have been so many studies that it's worth summarizing and noting the Cochrane review of 35 studies of ultrasound guidance for IJ placement. And this analyzed a pool patient population of over 5,000. In this Cochrane review, they found that ultrasound guidance reduced the overall complication rate by 71%. There was a 12% increase in overall success, a 57% increase in first attempt success, and there was a mean of 1.2 fewer attempts when ultrasound guidance was used compared to the landmark technique. In fact, in 2001, the Agency for Healthcare Research and Quality, or AHRQ, published a best safety practices document. And in it, they listed ultrasound-guided central line insertion as an evidence-based practice deserving of more widespread implementation. And ultrasound-guided central lines, this is really the first and is currently still the most widely used procedural application in POCUS. Another reason why POCUS is important is that many professional organizations and medical societies have published statements and guidelines regarding its use. And these are important for clinicians in these specialties to be aware of. Perhaps the most important of these dates back actually to 1999 when the AMA published this resolution. And it said that ultrasound imaging is within the scope of practice of appropriately trained physicians, that broad and diverse use of ultrasound imaging exists in medical practice, and that ultrasound privileges should be based on recommended training and education standards developed by each specialty. This was such a huge step for POCUS and really validated the use of this imaging tool by various specialties and promoted acceptance of its use throughout the medical community. Since then, we've seen statements from many specialties, some of which you see here: emergency medicine, critical care, surgery, anesthesia, neurology, and many others. Another important aspect of POCUS is that it's on the American Board of Pediatrics radar. It's actually been incorporated into my subspecialty board exam since 2010, and I found it as part of the entrustable professional activities for pediatric nephrologists. Another important aspect to consider is that POCUS improves our accuracy of the clinical exam. And we know from previous studies, and I'm going to show you a few of these in a bit, that many of our physical exam skills, the ones that we so diligently learned in medical school, in many cases are neither accurate nor reliable. But I want to be clear that I'm not proposing that we should be using ultrasound and abandoning the physical exam altogether. Instead, the way that POCUS is designed is to be incorporated into the clinical exam in order to assist us in our bedside decision-making. As an example of the limitations of the physical exam, I want to show you this fun study was published in 2005. They took 2 first-year medical students and gave them 18 hours of echocardiography training using a hand-carried ultrasound. They were asked to identify pathology in a group of 61 adults who they knew had pre-existing disease. It had already been diagnosed on standard echocardiography. And they compared those findings to those of a board-certified cardiologist who used standard physical exam skills, including auscultation with a stethoscope. And what do you think they found? The medical students with ultrasound were able to detect 75% of the pathology, whereas the cardiologists were able to only identify 49% of the pathology with their physical exam. And this study was not about commenting on cardiologists' physical exam skills. It highlighted rather the limitations of the clinical exam and also the feasibility of POCUS. Many other studies, some of which I have here on this slide, have also demonstrated the limitations of the physical exam, specifically with the evaluation of abdominal injuries, appendicitis, pleural effusions, pneumonia, and asthma, for example. And I want to highlight a study that my colleagues and I did looking at the clinical exam specifically for soft tissue infections. And the question that we wanted to ask was, how reliable is our clinical exam for evaluating these infections? We all know that soft tissue infections represent a spectrum of disease. So on the one hand, we have a cellulitis that's just going to respond to systemic antibiotics. But on the other side, we have an abscess that needs to be drained in order to be treated. And then there are those in the middle. And those are the ones that are tricky because we're often unsure. They're not as obvious. So we performed a cross-sectional study, and 2 physicians from a pool of 62 evaluated patients with these lesions. Physicians used this Likert scale at the bottom to declare how certain they were with their diagnosis. And we analyzed reliability, also called agreement, between the 2 physicians using a weighted Kappa. And if you're not familiar with a weighted Kappa, it basically gives you partial credit. So for example, if one of the physicians said, definitely no abscess, and the other said, probably no abscess, that would not count as complete disagreement. Some credit would be given for agreement. Versus if one physician said, definitely no abscess, and the other said, definitely an abscess, that scenario would get no credit. And we specifically asked physicians 2 questions. First, whether there was evidence of an abscess, and second, whether they felt the lesion required a drainage procedure. Because as we know, you might have a small collection of pus that's technically an abscess, but it might not need a full drainage procedure. Maybe it'll heal with some warm compresses, maybe some antibiotics. And here's what we found. Physician agreement for diagnosing an abscess and for determining if it needed to be drained, just based on our clinical exam, was not very good. As measured on the Kappa scale here at the bottom, you see agreement was fair and moderate at best. And what we concluded was that the reliability of the clinical exam alone for the evaluation of soft tissue infections was inadequate. And at the time of that study, there had been a couple of adult studies which demonstrated the accuracy of POCUS by general emergency physicians for identifying soft tissue infections. So then we asked the question, can pediatric emergency physicians do the same thing in children? As a next step, we wanted to know if novice pediatric emergency physicians could be adequately trained to use POCUS for the evaluation of soft tissue infections. So we had study physicians undergo a 1-day training course, and then they performed a set number of ultrasound exams on patients with soft tissue infections, and they saved their images and video clips, and they interpreted the images. All exams were subsequently reviewed by an expert who evaluated 2 components of the exam. The first was quality, and he basically looked at the images and rated them on a technical scale using 4 points, with 4 being the highest, optimal quality. And then the expert also interpreted the exams, and we analyzed the agreement between the study physician and the expert for whether there was an abscess or cellulitis. Of the 107 exams, the mean quality score was 3.3, with 4 being the highest. And the agreement for whether or not it was an abscess between the study physician and the expert was 0.8, which, if you remember from my previous slide, is considered substantial agreement on the Kappa scale. And so we concluded that novice physicians could learn these exams. So now we felt comfortable that this was a skill that we'd be able to perform. So we then sought to determine the added benefit of POCUS when incorporated into the clinical exam. And we first asked physicians to classify infections as being clinically evident or not. If the physician wasn't sure, based on their clinical exam, if the lesion needed drainage, we define those as not clinically evident. The outcome measure was abscess that required drainage, and we ultimately evaluated 387 infections. What we found was that for clinically evident lesions, so those that the physician examined and felt really confident that the lesion was a cellulitis or it was a drainable fluid collection, the accuracy for those lesions was very high. So there really was no added benefit in using POCUS. Where POCUS really benefited patients and improved the diagnostic accuracy was for those lesions that were not clinically evident. The sensitivity increased by 34% and the specificity by nearly 20%. There have been several studies and meta-analyses of bedside soft tissue ultrasound in children, and the pooled data support its use to improve our diagnosis. And it's probably the most commonly performed POCUS exam in pediatric emergency medicine. Now, I've touched on skin and soft tissue infections, and now I want to talk more about some other indications for which we can use POCUS in pediatrics. This slide gives you an idea of the scope of POCUS applications, and I want to first highlight some specific examples through some cases, specifically from our emergency department, and then I will mention some more applications in other areas as we move through the talk. Let's start with this 14-year-old with DKA. We see a lot of diabetic patients in the ED, and unfortunately, some of them will present in DKA. And as you all know, these patients are very sick. They're volume depleted, acidemic. It can be very difficult for our nurses, who are phenomenal, by the way, to obtain IV access. And in order to manage them effectively, we need 2 IVs, preferably large ones. So putting a tiny 24 gauge in the wrist really isn't going to cut it for these patients. And it's not uncommon that we have multiple failed attempts. So we'll often use ultrasound to assist with PIV placement in these patients. And it allows us to access the non-palpable or deeper veins. Here you see the vessel we were able to access with the tip of the IV catheter inside. And our vascular access team, many of you have probably seen, are well skilled in using ultrasound. Some of our ED and ICU nurses and physicians are also adept at using ultrasound guidance for PIV placement. And it's very interesting because over the years, what I've seen is that many of our chronic patients will come in, and they're very savvy now. They know that this tool exists. So many of our sickle cell patients, for example, will come in and ask for their IV to be placed under ultrasound guidance. I plead with my kids to please not walk barefoot outside, and this is why. This was a boy who presented with refusal to bear weight on his left foot. And on his ultrasound exam, he had evidence of a foreign body visualized by these arrows here and here. And with ultrasound, we can tell not only if there's a foreign body, yes, no, but we can also see how deep it is, how big it is, and if there are any important structures nearby, like a vessel or a nerve, that may complicate the removal procedure. This was a particularly interesting case of a 17-year-old medically complex male. He was nonverbal and had a history of urosepsis. On that particular day, he had presented to the ED with fever and hypotension. He was febrile, tachycardic, tachypnic, hypotensive, and had very poor perfusion. So of course, our initial impression was that he was septic. And we thought it was likely secondary to a UTI, given his history of urosepsis. And of course, we sent the usual cultures and started broad spectrum antibiotics and began to initiate IV fluid boluses. So as we typically do with patients like this, we administered 2 20 per kilo IV boluses rapidly. And when we repeated his vitals, you can see here that they were completely unchanged. So we gave him a 3rd bolus. And ultimately, after 60 per kilo, we reassessed his vitals. They still hadn't changed. And at that point, we did a POCUS exam. And let me know, and I'll let you know what that looks like here. So if you're not used to reading echocardiograms, I'll point out the most important parts of this exam, which are the fluid around his heart and the diastolic collapse of the right ventricle. His right ventricle was not filling adequately. In fact, this patient had cardiac tamponade, and that's why his blood pressure was not improving. So cardiology ultimately drained about 10 per kilo off of his heart, and they did it under ultrasound guidance. And he recovered quite nicely, fortunately, without a recurrence. And after many tests, which came back negative, he was suspected to have had a viral pericarditis. Here's another case of an adorable little 2-year-old who came in with a limp. And it was actually pretty subtle. Of course, when we walked her in the ED, it was much better than it had been at home, which is usually the case. And by evaluating her hips with ultrasound, we could tell that the limp was coming from a hip effusion. And this led us ultimately to a diagnosis of transient synovitis. So this was an 18-month-old little girl who was having diarrhea for 4 days. She was also febrile to 103. She had abdominal pain. During viral gastro season, those of you who have been down to the emergency department know that these kids are so common. They come in fast and furious. And in fact, she had actually been to our ED on day 1 of illness and was diagnosed with gastroenteritis, which at the time was certainly appropriate. When she represented 4 days later, she really seemed to be more tender than we might expect. And her illness really seemed to be dragging on for longer than we might expect too, particularly with her fevers. Here's her bedside abdominal ultrasound, and these images that I'm showing you focus on her right lower quadrant. And I'll direct your attention to the area of free fluid, which you can see better in this still image. And the combination of her fevers, tenderness, and the free fluid in her right lower quadrant prompted us to do a CT scan and revealed a perforated appendicitis. My colleague was taking care of this patient, and she very astutely recognized as soon as she walked in the room that this young man just did not look well. He was tachycardic, fatigued, diaphoretic, and she quickly considered cardiac pathology on the differential diagnosis and performed a focused echocardiogram. In this view of the heart, this is the right ventricle. Here's the left ventricle. And here we see the mitral valve. And I'll show you this compared to what a normal exam should look like. And I want you to look at this heart, and I hope that everyone can appreciate that this heart is failing. And to support this diagnosis, she also evaluated his IVC and found a very large, what we term plethoric IVC, which of course was due to the elevated central venous pressure from poor cardiac contractility. Here you see his IVC next to a normal IVC for comparison. And in fact, he was diagnosed with a dilated cardiomyopathy and ultimately received a heart transplant. I had a 15-year-old hockey player present the day after he played a game. At that time, he said he was hit in the abdomen. He didn't know if it was a fist or a stick or a helmet. He immediately threw up after the game, but he went home and he decided to shake it off. And he continued to have intermittent vomiting, and the pain seemed to be getting worse. So the next day he presented. He had no external signs of trauma, and he was tender mostly in the bilateral lower quadrants. Here are images from his pelvic view. This is one of the views of the FAST exam, and you can see the large area of free fluid all around the bladder. We proceeded with a CT, which showed a jejunal perforation. He was immediately taken to the OR, and he did quite well. Let's do one more case. So in the emergency department, we as attendings carry pagers, and the pagers alert us to patients that are arriving by ambulance. So during a shift, I got this page. 18-month-old found floating in the pool. CPR in progress, ETA 8 minutes. So the patient arrived and EMS was performing CPR. We transferred her over to the stretcher, and immediately we needed to know, does she have a pulse? And this is actually sometimes a really hard question. Sometimes we can't feel it when it's there. Sometimes we think we feel it, but it's really our own pulse that we're feeling. Let me show you some data. This was a study about a decade ago now out of Australia, and it was really interesting how they designed it. They had volunteer physicians and nurses assess children who were hospitalized on ECMO in different stages of cardiac recovery. So some patients had a palpable pulse and some did not, but the volunteers didn't know which. The volunteers had to determine whether they thought the patient had a palpable pulse. For the 55 assessments where there was no true palpable pulse, about 75% of the time, the volunteers were correct. And for the 98 assessments where there was a true palpable pulse, about 80% of the time, the volunteers were correct. And I like to think about this study in the reverse. For those without a pulse, the volunteers erroneously thought that there was a pulse about 25% of the time. So you can imagine that would mean missed opportunities to perform CPR in about a quarter of patients without a pulse. For those with a pulse, the volunteers said there was not a pulse 20% of the time, and those patients would have gotten CPR that they really didn't need, which probably isn't such a big deal. It's really that first group where 25% of the time they thought they were detecting a pulse in a patient who didn't have one. So here's another example of the limitations of our clinical exam. So we'll go back to the case, and here's where ultrasound can help in patients with cardiac arrest. So I want you to just notice the timestamp at the top of the screen. This first clip was taken at 11:08, and you can see that there's no cardiac activity. The only thing moving is blood that's static, that's swirling around inside the left atrium. This is a repeat clip 5 minutes later after CPR and epinephrine during another pulse check at 11:13 a.m. And it's important to note that these images are taken during the pulse check. We're not pausing CPR to do this. We're not spending any more than 10 seconds doing this exam. Here we are 9 minutes later at 11:22. And finally, here we are at 11:23. And at this point, by everyone's standards, the patient had a palpable pulse. And these images really provided visual confirmation of cardiac movement. Now I want to move out of the emergency department and talk about what we're doing locally with respect to POCUS. We have a very active POCUS program at all aspects of our health system, and I'm going to touch on all three of these. First, I want to share details about the hospital-wide program here at Children's. In 2015, it became apparent that several of the divisions at Children's were using POCUS, but everyone was doing something a little different, and there really was no standardized approach to using this tool. So we decided it was important to consolidate efforts and make sure that as a hospital, we were all utilizing POCUS consistently, responsibly, and in an organized manner. And Steve DeSimo, who many of you will remember was our former CMO, tasked me and this man, Ashok Panagrahi, with developing a policy specific to POCUS use. And this was the first hospital-wide POCUS statement at UPMC. And the policy includes details about appropriate documentation and archiving, as well as quality assurance practices. From there, the program really grew, and Children's is really, as Maya said, a pioneer in this area. We were one of the first and are still one of only a handful of children's hospitals to have this kind of program. Currently, the program includes 15 specialties. Each division has a POCUS lead or champion. And in the next few slides, I'm going to give you a flavor for what some of the divisions are doing. Mihaila Vizu is in charge of the anesthesia POCUS program, and our anesthesiologists use ultrasound very routinely for vascular access, as well as for regional anesthesia, both in the OR and on the pain service. And here you see examples of two types of nerve blocks. Tim Kaislitz is our PICU lead, and you can see the long list of exams that our intensivists use ultrasound for. Here I have examples of a pleural effusion, signs of interstitial fluid on lung ultrasound, and an IVC exam. Yolandi Belchetter is in charge of the CICU POCUS program, and our cardiac intensivists use POCUS not just to evaluate the heart like you might expect, but also to evaluate for pleural and abdominal fluid. Corinna Lawrence runs our NICU program and has focused on ultrasound in medical education. During her fellowship, she studied a training curriculum for APPs to use ultrasound for central line tip verification, which she showed reduced the number of x-rays that our neonatal patients are exposed to. Mike Moritz represents the Division of Nephrology, and our nephrologists use ultrasound to evaluate patients with renal transplants, those with congenital lesions, hydronephrosis, and also bladder volume assessment. Hoda Abdelhamid started the neurology ultrasound program, and she's interested in ultrasound for neuromuscular diseases such as muscular dystrophy. Ken Nischel's in charge of our ocular POCUS, and our ophthalmologists will use ultrasound to assess every last layer of the eye. And it consistently amazes me how much they can see with ultrasound, given how small of an organ they're dealing with. This is an example of a patient with pseudopapilledema who ended up having ocular drusen. And the patient on the right was actually recently diagnosed in our ED just a couple weeks ago with unilateral visual loss and a posterior vitreous detachment. Daniel Keats from Rheumatology is an expert in musculoskeletal ultrasound. He uses ultrasound to assess for joint pathology and also for procedural guidance when performing arthrocentesis. Stefan Schultz has extensive experience with ultrasound. He actually edited the textbook that you see here on ultrasound in pediatric surgery. And in addition to what you might expect our surgeons to use ultrasound for, he actually uses it to assist with surgical planning for children with imperforate anus. And Glenn Cannon represents urology. And I have to admit that our urology division is, I was surprised that they are the most active in terms of ultrasound. All of their faculty, all of their APPs use POCUS in their daily practice, and they've actually been doing so for several decades. Now, everything I've shown you thus far about our hospital program is really related to the clinical aspect. That's only one component, though. We work very closely with support staff from several other areas of the hospital. I am indebted to the folks in biomedical engineering, clinical informatics, our department of quality and safety, and the others that you see here. It's truly a multidisciplinary program that requires collaboration with many different areas of the hospital. And it's not only our subspecialists actually who are using and learning POCUS. Another unique aspect of children's is that our pediatric residents have the opportunity to learn POCUS. And this is also very rare in pediatrics residencies. In 2015, Desiree Neville, who's one of the pediatric emergency medicine faculty, designed an immersive 2-week elective for our residents in which they get one-on-one didactics and dedicated practice time in our emergency department. You can see photos here of some of our recent residents on the rotation. And over the last 6 years, this rotation has grown exponentially in popularity. More than 50 of our residents have taken her elective to date. And a couple years ago, I did some calculations and I found that more than 1/3 of our residents in a year were requesting this elective. But Dr. Neville is only one person, so she consistently has to turn away resident requests. Here's some data based on feedback from her elective. This is self-reported comfort with POCUS, both before and after her elective. And after just a 2-week experience, the residents felt more comfortable using POCUS. Across the health system, there's been an effort to better coordinate POCUS use. In fact, as of last year, there's now a system-wide POCUS policy that was developed across many disciplines, including pediatrics, emergency medicine, critical care, anesthesia, cardiology, and radiology. We have a system-wide multidisciplinary POCUS conference that occurs quarterly and has continued remotely actually through COVID. It's very well attended and a different department presents each time. POCUS training has also been incorporated into the Pitt Med School since about 2013 actually. One of my colleagues in critical care medicine developed a program focused on exclusively undergraduate medical education. And it's called IPOCUS, which stands for Interdepartmental Point of Care Ultrasound. You can see all the departments that contribute here. iPOCUS offers a fourth-year medical student elective and also a first-year mini elective. Students have a flipped classroom experience for the didactics, and then they actually spend their class time doing hands-on scanning shifts where they practice these ultrasound exams on real and standardized patients at Weiser. It is absolutely one of the most popular electives in the medical school. So what's next for POCUS? And I think it's a very important issue moving forward that we need to overcome some of the barriers, the most important of which is learning the skill. There are many practicing physicians today that didn't receive this training as part of their residency or their fellowship. And it's really hard to learn a new skill and incorporate that skill into your practice after you've been doing something a certain way for decades. There are other barriers too to learning POCUS. This is data from a survey that Noelle Zuckerbrand and I did back in 2012 of pediatric emergency medicine fellowship directors. And as you can see, time to learn was the most common barrier. Other barriers were lack of personnel to train faculty and time in the ED to use it. And although we have increased our number of individuals available to train faculty, giving people more time in the ED to learn is not something that's easy to come by, as you can imagine. Another important issue is how best to train clinicians. How many exams do we need to achieve competency? How should we assess competency? Should it purely be numerical benchmarks, a certain number of exams? And these are questions that we continue to ask in the POCUS world, and we have yet to definitively answer. On this note, I do want to mention that since this is still a relatively new field, certainly in pediatrics, there's tremendous potential for high quality research studies to be done. We need more evidence that evaluates patient-centered outcomes. The area is very ripe for QI initiatives and educational interventions. And of course, in pediatrics, where pathology can be much less common than in adult patients, POCUS really represents an important area to be studied using multi-center data and trials. In fact, PCARN is actually working on a multi-center study of the FAST exam as a follow-up to their single-center study that was published a couple years ago. So stay tuned for those results in the next couple of years. Now, we've talked a lot about ultrasound in the hands of physicians, but POCUS is being used by many other health providers, and studies are coming out which address these specific populations. I put a question mark by primary care because to my knowledge, there are no studies looking at this environment yet, but I think it's also an area very ripe for ultrasound use as well. Being that we're in the 21st century, and not only is ultrasound equipment becoming smaller and more portable, but the technology is also becoming smarter. The latest would be through the use of artificial intelligence. So there are automations that actually assist the ultrasound user to optimize their acquisition of images. And the system uses scan quality indicators for this. Some machines will also provide auto calculations for things like cardiac output, evidence of lung congestion, and IVC collapsibility. In the past, we would have to do multiple images, multiple scans, and multiple measurements in order to get these calculations. But now the machine is smart enough to do this with one or two views. And these machines also allow for time series analysis so that changes can be tracked over time. And I want to spend the next few minutes talking about what is really such a big topic in POCUS, that of ultrasound in undergraduate medical education, even beyond what I shared with you going on here at Pitt. This is becoming, and in some programs it already is, a standard part of the medical school curriculum. And I want to highlight one of the pioneers in this area. The University of South Carolina School of Medicine. Their former dean, Richard Hopman, was incredibly supportive and had this vision to have ultrasound integrated into all 4 years of the medical school curriculum. So much so that he founded an ultrasound institute, which is a state-of-the-art facility dedicated to ultrasound training and has phantoms, standardized patients, and high-end ultrasound equipment. It's similar to what we have at Weiser, but it's all ultrasound. Initially, when the program was started, when first-year medical students got to campus, they were given their stethoscope and their otoscope and a handheld ultrasound. And other institutions have followed suit. In fact, the development of the Ultrasound Institute at the University of South Carolina actually led to the birth of this organization called the Society of Ultrasound in Medical Education, or SUSME, which is really at the forefront of ultrasound teaching in medical school. To give you a sense of how some are viewing ultrasound in medical education, I want to share with you this New England Journal perspective. This is from 2014, and it was written by two cardiologists at Brigham and Women's Hospital. They made a strong case for the need for POCUS training as part of medical education, and in it, they said a generation of physicians will need to be trained to view this technology as an extension of their senses, just as many generations have viewed the stethoscope. That development will require the medical education community to embrace and incorporate the technology throughout the curriculum. So now we see a lot of physicians who look like this, but soon we may be seeing a lot more who look like this. So I'd like to close. In summary, we've talked about a lot of different aspects of POCUS, including what POCUS is, how it differs from more comprehensive ultrasound studies, some of the benefits of POCUS, including the higher accuracy compared to the clinical exam alone, how POCUS increases patient safety when used for procedural guidance. I've touched on several of the applications through these discussions, through case-based discussions, and I shared with you details of the CHP POCUS program and also highlighted what's happening UPMC-wide and at our medical school. And finally, we discussed the future of POCUS with an emphasis on medical education. I do want to take this opportunity to acknowledge and thank some key influential people. First, Rick Saladino, who shared and supported my vision to bring POCUS to our emergency department 10 years ago. To Steve DeSimo, who supported the initial development of a CHP-wide ultrasound program. And Brian Martin, who's continued this support and ensures that we have the resources in order to thrive. And finally, Diane Hupp, who has consistently supported the program's equipment needs each and every year. And with that, I want to thank you so much for your attention, and I'm happy to take any questions.
Thank you so much, Dr. Marin. That was a fantastic presentation. We have a couple questions in the chat or in the Q&A. So first, I think is a comment saying that they're actually already utilizing it in medical genetics for cryptic anomalies, genotype in broad spectrum molecular testing like exam, picked up silent anomalies that are influencing management. So it sounds like they're already using it there. So that's fantastic. Dr. Lambour said, Dr. Marin, excellent presentation and indeed absolutely very educational. Thank you. I'm a strong proponent of a thorough physical exam. Over the years, I have tirelessly worked on training our medical students and residents to become master clinicians. My concern is if POCUS becomes an adjuvant to physical exam, our trainees will rely less or would never master the skills on physical exam. The case you mentioned about a 14-year-old complex patient with fever and hypotension perhaps could not get a cardiac exam, distant heart sounds or inaudible sounds on top of nod. Is that correct?
Yes, so I think that, as I said, I totally agree with you, Sanjay. I don't think that this should supplant the physical exam, and it is important to master that, and this should be used as an adjunct to support it. The patient that I did show you, distant heart sounds, that's a really hard one. He was very scoliotic, his exam was very challenging, so that was not something that we were able to appreciate on exam. And that happens a lot with, I think, a lot of the exams that we do. It can be challenging. And as I've shown you, there are limitations to the clinical exam. But again, I absolutely agree with you. I do not think that we should abandon the physical exam.
And Dr. Diego says, thank you for a wonderful presentation. It was clear that POCUS has a lot of advantages. One of them I can see is a technical resource that can save in costs and patient care. Locally, the Birmingham Clinic is using POCUS in caring for uninsured patients. I'm wondering if you have any information about it, if you could elaborate about cost savings in caring for uninsured patients. Thank you.
Yeah, I think that's an interesting question. I imagine that there are cost savings. I don't necessarily have any data to that effect, but I hope that the folks over at the Birmingham Clinic would consider studying that and looking at that data, because I think that's actually an application that is worth noting. It's not something that I had considered, but I think it's a really good point.
Thank you so much. Those are all the questions currently in the Q&A. So thank you so much. This was fantastic. I think everyone would love to have you join us over at the meet and greet to continue this conversation over there. You can see the link in the chat. Thank you so much, Dr. Marin.
Thank you, guys.